Imagine you're tasked with restoring the facade of this centuries-old priceless masonry building.
Oh, that sounds stressful already.
Right, so you need to strip away this really stubborn layer of surface grime, and you just reach for the absolute most aggressive industrial solvent you can find.
Which I'm guessing works a little too well.
Exactly. It obliterates the grime in seconds. But there's this massive unseen cost, right? The solvent is highly acidic, and it silently eats away at the historical mortar that's holding the entire structure together.
Yeah, so you've solved a temporary surface problem, but you've permanently compromised the actual foundation.
Bingo. And that is exactly the tightrope we are walking today in the highly specialized realm of medical aesthetics and dermatology.
It's such a delicate balance.
It really is. The question is, how do we completely numb the skin, achieving profound pain relief for intensive dermal procedures without chemically altering the local pH and destroying our cellular foundation, specifically our polynucleotides?
It is honestly one of the most elegant physiological puzzles in modern pharmacology. You know, you are attempting to negotiate with a biological barrier that is evolutionarily designed to reject foreign substances.
Yeah, it wants to keep everything out.
Exactly. But you have to do that while simultaneously protecting the microscopic, incredibly delicate environment of the skin cells right beneath it.
So, to figure out exactly how this is done, we have gathered a really dense stack of source material for you today. We're looking at advanced pharmacological research on anesthetic formulations, clinical dermatological guidelines on permeation protocols.
And some incredibly detailed biochemical studies, right?
Yes, specifically focusing on the exact mechanisms of DNA degradation. Okay, let's unpack this because before we can understand the solution, we have to look closely at the fortress we're trying to breach.
The skin itself.
Right. If you're applying a topical cream, the absolute first line of defense it encounters is the stratum corneum.
And we really have to respect the architecture of the stratum corneum. I mean, a lot of people think of the skin as a sponge, but structurally, it is much closer to a brick and mortar wall.
A masonry building analogy.
Exactly. The bricks are your corneocytes, which are these tough, dead, keratin-filled cells. And the mortar holding them together is this highly organized matrix of intercellular lipids.
Mostly ceramides and cholesterol, right?
Yeah, ceramides, cholesterol, and free fatty acids. And that lipid mortar is aggressively hydrophobic. It is engineered to keep water inside your body and keep external water-soluble threats completely out.
So, because of that intense brick-and-mortar architecture, bypassing it takes significant time and the right chemical strategy.
It's not an instant process by any means.
No, not at all. According to the dermatological guidelines we reviewed, if you just want to achieve surface layer numbing, which penetrates about 1 millimeter deep for superficial procedures, it requires anywhere from 30 to 90 minutes of continuous exposure to a topical anesthetic cream.
Which is already a substantial clinical window, but it gets even more challenging if a clinician is performing deep dermal work.
Like what kind of procedures?
Well, if you're looking at aggressive fractional laser resurfacing or deep microneedling, maybe minor excisions, for those, you need that anesthetic blockade to reach down to a maximum depth of about 5 millimeters.
Wow, 5 millimeters is pretty deep for a topical cream.
It really is. To force a drug that deep through the stratum corneum without using a needle, you are looking at up to 120 minutes of continuous application.
2 full hours just to prep the canvas.
Exactly.
And the standard pharmacological tools used to achieve that profound depth are commercially available creams that combine different anesthetic agents. The most prominent example in our sources is a compound containing 7% lidocaine and 7% tetracaine.
Yeah, and they use those two in tandem because their pharmacokinetic profiles complement each other perfectly. Well, lidocaine has a lower pH, meaning it remains largely unionized at physiological pH. So that allows it to penetrate quickly and spread extensively.
Okay, and the tetracaine.
Tetracaine, on the other hand, is highly lipophilic. I mean, it is incredibly fat-soluble, and it binds tightly to proteins, which gives it a much longer duration of action once it actually gets where it needs to go.
Right, down to the nerves.
What's fascinating here is the precise biophysics of how those molecules actually halt the sensation of pain once they navigate past that lipid mortar. They are targeting the sensory nerve endings located deep in the dermis.
Okay, so how does it actually stop the pain signal?
So the membranes of these nerves are embedded with voltage-gated sodium channels. In a normal state, when a painful stimulus occurs, these channels open up, allowing a massive influx of sodium ions right into the nerve cell.
Which triggers the signal, right?
Exactly. It depolarizes the membrane and fires an action potential, basically an electrical signal that travels up the nerve fiber to your central nervous system.
So the anesthetic molecules have to, like, physically intercept that process.
Yes. Local anesthetics cross the nerve sheath and actually bind to the intracellular portion of those sodium channels. They basically act like a molecular plug.
A microscopic cork.
Pretty much. When the painful stimulus happens, the channel tries to open, but the sodium cannot rush in. Depolarization fails, the action potential is never generated, and the central nervous system registers absolutely nothing.
That's incredible. But getting that molecular plug down to the nerve is the fundamental hurdle here. Because if the stratum corneum is sealed with a lipid mortar, we clearly cannot use a water-based delivery system.
Right, oil and water don't mix.
Exactly. And this brings us to a massive distinction in pharmacology that completely dictates whether a drug can cross that barrier. The difference between salt forms of a drug and base forms.
This is where the chemistry becomes critical. When pharmaceutical companies synthesize anesthetics, they generally produce them in one of two states. You have your hydrochloride salts.
The HCl salts.
Yeah, the HCl salts. And then you have the non-salt uncharged forms, which we call the base forms.
Looking at the HCl salts first. The literature notes that they are highly water-soluble. That makes them incredibly easy to formulate into standard solutions.
They dissolve beautifully in water.
But there is a severe drawback when we talk about biological compatibility, right? They are highly acidic.
Very acidic.
Standard lidocaine HCl has a pH hovering around 6.09, and it drops even further when it's combined with epinephrine.
Which clinicians frequently use, by the way, to constrict blood vessels and reduce local bleeding during procedures?
Right. But because epinephrine is highly unstable and prone to oxidation, the manufacturers have to add acidic preservatives. Things like sodium metabisulfite.
Yeah.
And that drags the pH of the entire solution down to a highly acidic 4.2.
To really understand the physiological impact of that, you have to consider that the body's natural extracellular pH is tightly regulated. It normally sits between 7.35 and 7.45.
And the pH scale is logarithmic.
Exactly, it's logarithmic. So a drop from around 7.4 down to 4.2 indicates that the anesthetic solution is roughly over 1,000 times more acidic than the living tissue it's entering.
But wait, I want to challenge the formulation logic here. Because if HCl salts are so easily dissolved in water, and our bodies are, predominantly water, why don't clinicians just use the water-soluble salts on the skin?
It seems like it should work, right?
Yeah, like why does the acidity even matter if it gets the job done?
Well, it goes back to the architecture we established earlier. The skin's barrier isn't water, it's that lipid mortar, the fats.
Oh, right, the hydrophobic Bruxin mortar.
Exactly. HCl salts are fantastic for penetrating mucous membranes, like the mucosal lining in dentistry, which lacks a keratinized stratum corneum. But if you put an aqueous HCl salt on intact epidermis, it will simply pool on the surface.
It just sits there.
It just sits there, completely repelled by the fats. Furthermore, if you somehow manage to artificially force that acidic solution into the DR tissue, you would be dumping a massive load of hydrogen ions into a finely tuned physiological environment.
Drastically dropping the local pH.
Drastically, which is exactly what we want to avoid.
So the solution is to abandon the water-soluble salts entirely when dealing with intact skin. Instead, dermatologists rely on the base forms of the anesthetics.
Yes, the uncharged base forms.
And the way these base forms are utilized relies on a phenomenon called a eutectic mixture. But I am genuinely stuck on the mechanics of this concept, I'm not going to lie.
It sounds like magic, honestly.
It really does.
Yeah.
Our sources state that if you take two dry, crystalline powders, pure lidocaine base and pure tetracaine base, and you simply mix them together, they transform into a liquid oil at room temperature.
Just by mixing them.
Right. How does that happen without adding any kind of liquid solvent?
It seems totally counterintuitive, but it's purely structural physics. In their isolated states, lidocaine and tetracaine molecules are arranged in rigid, crystalline lattices held together by intermolecular forces.
Which is why they're solid powders at room temperature.
Exactly. However, their molecular shapes are highly asymmetrical relative to each other. So when you physically blend them together, the molecules of lidocaine interfere with the crystalline lattice of the tetracaine and vice versa.
They just don't fit together.
Right. They disrupt the van der Waals forces and hydrogen bonding that normally keep each other solid.
Oh, wow. So they essentially destabilize each other's solid state.
Precisely. Because the lattice is completely disrupted, The combined melting point of the mixture drops drastically well below standard room temperature.
That's wild.
Yeah, so the solid powders just melt into each other, creating a pure, concentrated, lipid-soluble oil. And they do this without the need for water, alcohol, or any other chemical wetting agent.
And because this eutectic base is practically a pure lipid, it is highly lipophilic. It is uniquely capable of dissolving straight into the ceramide and cholesterol mortar of the stratum corneum.
It permeates the barrier incredibly smoothly.
But the physical state of the drug is really only half the victory here. The far more consequential benefit of using this base form is that we completely avoid exposing the skin tissue to the extreme acidity of the HCl salts.
Which brings us to the core biochemical threat we are trying to avoid. The whole reason we are so deeply concerned with maintaining a neutral physiological pH in the dermal layers is the vulnerability of our polynucleotides.
Our genetic material.
Specifically, the structural integrity of our DNA and RNA.
Okay, here's where it gets really interesting. When polynucleotides are subjected to an acidic environment, they undergo a rapid, destructive biochemical reaction called depurination.
Depurination, yes.
And the actual chemistry here is fascinating. Your DNA is a double helix built from nucleotide bases. The purine bases, adenine and guanine, they're attached to the sugar phosphate backbone by what is called an N-glycosidic bond.
Which is a very specific, crucial linkage.
Right. And when the pH drops and the environment becomes flooded with excess hydrogen ions from an acidic anesthetic, those hydrogen ions protonate the purine base.
And that protonation is just catastrophic for the molecule. It creates a severe electronic instability at that exact N-glycosidic linkage.
It just weakens it.
More than weakens it. The bond simply cannot hold under that stress, and it hydrolytically cleaves. The DNA literally sheds its purine bases, leaving behind an apurinic site.
So it creates a literal gap in the genetic sequence.
Exactly. You are structurally degrading the DNA within the living cell.
And the research in our sources explicitly details how aggressively pH-dependent this rate of degradation really is. Like, there is a massive exponential spike in DNA cleavage when the pH drops below 2.5.
But even at milder levels, it's an issue.
Exactly. It's a persistent escalating threat, even at mildly acidic levels. And the terrifying part is that our cells are already fighting a baseline level of this degradation naturally.
Just from being alive.
Right. The biochemical data estimates that a single human cell naturally loses anywhere from 2,000 to 10,000 purine bases every single day, just from ambient hydrolytic depurination.
And our cellular repair mechanisms are constantly working to patch those apurinic sites.
So if a clinician were to force a highly acidic solution, like an unbuckered pH 4.2 lidocaine and epinephrine salt, into that environment, what happens?
They would be massively accelerating that rate of depurination. It places extraordinary osmotic and biochemical stress on the tissue. And practically speaking, this often manifests clinically as an intense burning sensation upon application or injection.
Ouch. So the imperative is crystal clear.
Yeah.
We must keep the local pH neutral to protect the genetic architecture of the tissue. But there is a secondary, equally important reason for maintaining that neutral pH, and it has to do with making sure the anesthetic actually functions at all.
Yes. If we connect this to the bigger picture, it all comes down to the Henderson-Hasselbalch equation.
Bringing out the heavy chemistry.
Always. It's all about the ratio of ionized to unionized drug. As we discussed, the anesthetic molecule needs to cross the lipid membrane of the sensory nerve to plug that sodium channel from the inside.
Right, the molecular cork.
But a molecule can only cross that lipid membrane if it is highly lipophilic, meaning it must be in its uncharged, non-ionized state.
Okay, so if the surrounding tissue environment becomes acidic, the abundance of hydrogen ions will attach to the anesthetic molecules, right? Giving them a positive charge.
Exactly. The drug becomes ionized. And once it holds a charge, it becomes water-soluble rather than fat-soluble.
Oh, and water-soluble things can't cross the lipid membrane.
Precisely. It literally bounces right off the lipid membrane of the nerve sheath. It gets trapped in the extracellular space and simply cannot reach the sodium channels.
So it won't numb you.
It won't work. But by utilizing the eutectic base formulation, the local environment remains at a neutral physiological pH of roughly 7.4.
Which is perfect.
It ensures two crucial outcomes simultaneously. One, it completely prevents the acid-catalyzed depurination of the cellular DNA. And two, it maintains the anesthetic largely in its uncharged state, ensuring maximum permeation right into the nerves for absolute pain relief.
It is such an incredible dual-purpose strategy. Knowing the intricate biophysics behind this, knowing we have this purely lipid-soluble base that preserves neutrality, how is it practically executed?
The clinical protocol.
Yeah, like what is the clinical protocol for applying this tetracaine and lidocaine eutectic mixture to guarantee that it safely navigates the stratum corneum without disrupting the cellular foundation?
Well, the clinical guidelines dictate a very specific physical protocol. The eutectic cream is applied strictly to intact skin, and it's typically spread in a uniform layer about 1 millimeter thick.
Okay, seems straightforward so far.
But they can't just leave it exposed to the ambient air. The absolute critical mechanism for driving the drug deeply into the dermis is applying it under occlusion.
Now, in a clinical setting, occlusion usually means covering the entire treated area with a physical impermeable barrier, right?
Yeah.
Like a plastic film wrap or a specialized medical dressing like Tegaderm. But is the occlusion just there to, stop the patient from accidentally wiping the cream off on their clothes? Or is there a biophysical purpose to it?
Oh, it is entirely biophysical. Occlusion radically alters the thermodynamics and the hydration gradient of the stratum corneum.
How does it do that?
Under normal circumstances, your skin is constantly losing a small amount of water to the atmosphere. We call this transepidermal water loss. But when you apply an impermeable plastic film, you trap that moisture, along with the natural heat radiating from the body.
Oh, so you are basically creating a microscopic greenhouse directly on top of the skin.
Precisely. The trapped moisture hyperhydrates the stratum corneum. The keratin-filled corneocyte bricks swell up with water, and even more importantly, the structural organization of the intercellular lipid mortar becomes looser and much more fluid.
Because of the heat.
Yeah, the trapped body heat slightly elevates the surface temperature, which increases the kinetic energy of the anesthetic molecules.
Wow, that totally explains the timing. By fluidizing the lipid barrier and increasing the thermodynamic activity of the drug, the occlusion slowly and passively drives the lipophilic eutectic base deeper and deeper into the tissue.
Exactly. Over that 60 to 120-minute window, it slowly permeates all the way down to that 5 millimeter depth.
And because the drug formulation is a neutral base, it is filling the extracellular spaces without dumping hydrogen ions into the environment.
Right. The cellular DNA remains structurally pristine while the sensory nerves are systematically shut down.
That is just brilliant.
And once that required dwell time is achieved, the preparation phase concludes with a strict removal protocol. The physical barrier is removed, and the clinician must meticulously wipe away the remaining cream with dry gauze first.
Why dry gauze first?
This removes the bulk of the lipophilic base without spreading it around further. Then, the area is thoroughly cleansed with wet gauze or an alcohol wipe to ensure the surface is entirely devoid of the anesthetic before any laser or microneedling procedure even begins.
So what does this all mean for you? If you are ever the patient sitting in a dermatology clinic, staring at the clock while covered in plastic wrap, it means you have to respect the physiological process.
You really do.
The chemistry demands patience. Rushing the clinician to start at minute 45 instead of minute 90 means you are denying the physics the time it needs to achieve deep permeation naturally.
And the alternative to waiting is using aggressive, tissue-damaging chemical enhancers, which nobody wants.
Nobody.
But this raises an important question regarding clinical safety and the absolute necessity of an intact barrier.
Intact skin, you mean?
Right. Every pharmacokinetic calculation we have discussed today, the steady diffusion rate, the predictable depth of permeation, it all relies entirely on the resistance provided by a healthy stratum corneum.
The brick wall has to be structurally sound.
It has to be.
What happens if the clinician applies this highly concentrated eutectic base to skin that is actively compromised, say, broken, severely inflamed, or recently resurfaced?
If the barrier is compromised, the resistance drops to 0.
Oh, no.
Yeah. The permeation kinetics become violently unpredictable. The body absorbs a massive, uncontrolled dose of the anesthetic directly into the systemic circulation almost immediately, rather than the slow, localized absorption we intend.
Which is incredibly dangerous.
Highly dangerous. These are potent pharmacological agents that affect voltage-gated sodium channels systemically, including the ones in the heart and the central nervous system.
Yeah, the sources are uncompromising on this point. Applying these highly concentrated anesthetics to compromised skin, or applying them over excessively large surface areas under occlusion, like wrapping entire legs for laser hair removal, can easily lead to systemic toxicity.
It's a very real risk.
There are actually documented FDA-reported fatalities resulting from patients self-administering numbing creams over huge portions of their bodies and wrapping themselves in plastic. The drug just bypasses the intended local tissue and builds to lethal concentrations in the bloodstream.
Which is why adherence to the guidelines regarding maximum surface area, strict dwell times, and application only to intact epidermis is an absolute clinical mandate. It is never just a suggestion.
It is incredibly humbling to zoom in and observe the massive biochemical dance happening during a routine aesthetic procedure.
It really is.
A patient walks in through a clinic, and the provider isn't just rubbing a soothing lotion onto their face. They are deploying advanced physics.
Absolutely.
They are utilizing eutectic molecular disruptions to create a purely lipid-soluble vehicle. They are manipulating thermodynamic gradients with physical occlusion to slowly bypass an evolutionary fortress.
It sounds like sci-fi when you put it like that.
Right. They are temporarily disabling the voltage-gated sodium channels deep within the dermal layer to halt action potentials. And they are orchestrating all of this while elegantly maintaining the exact physiological pH required to protect every single N-glycosidic bond in the cellular DNA from acid-catalyzed hydrolytic cleavage.
It is honestly the pinnacle of balancing profound pharmacological efficacy with meticulous cellular preservation.
Beautifully said.
But as with all scientific literature, the sources indicate that dermatological pharmacology is not stopping at simply doing no harm.
Oh, there's a next step.
Oh, definitely. If we know that polynucleotides are highly susceptible to protonation and cleavage under environmental stress, the next logical step isn't just avoiding acidity, it's actively fortifying the DNA against it.
Wait, how do you fortify DNA?
The biochemical research points to a fascinating frontier utilizing natural polycations.
Polycations?
Yeah, they are macromolecules that carry multiple positive charges. Things like chitosan, which is derived from crustacean shells, or spermine, which is an endogenous biogenic amine.
Okay, so they're positively charged.
Right. And because DNA is inherently negatively charged along its phosphate backbone, these positively charged polycations are naturally drawn to it. They wrap around the double helix, forming highly stable structures known as polyion complexes.
Like a microscopic shield.
Exactly. By physically shielding the polynucleotide, these polycations actively suppress the protonation of the purine bases. The research shows that chitosan can almost entirely inhibit DNA depurination, even if the local environment plummets to a highly acidic pH of 1.5.
Wow. pH 1.5 and the DNA survives.
It survives. Spermine provides similar structural armor across a vast pH range as well.
That poses an incredible question for the future of clinical aesthetics. I mean, what if the topical anesthetics of tomorrow don't merely avoid damaging the skin's genetic blueprint, but actually deliver these polycations directly into the cells?
That's the dream.
We could theoretically armor our polynucleotides on a molecular level, rendering our DNA impervious to the inflammatory and chemical stresses of the very procedures we are undergoing.
It's a profound shift from passive preservation to active biological fortification.
And a totally brilliant concept to consider the next time you find yourself covered in plastic wrap, waiting for an anesthetic to take hold.